We're K7, neck and C-spine. I'm Sam.
I'm Emma.
I'm Henry.
And I'm Sergio.
Hi, I'm Henry. I'm your student physical therapist today.
Hi, I'm Sam.
So what brings you into physical therapy today?
So I've been having this right-sided neck pain that travels into my mid-back, shoulder blade, and sometimes all the way down into my thumb and hand. Occasionally, I even feel it around the inside of my elbow. I work in an office, and I spend most of the day at the computer using a headset or sometimes the phone. I did have carpal tunnel surgery about 6 months ago, and I use a custom mouse because of that. I've always had pretty good posture from dancing ballet and doing gymnastics growing up, and I like to play pickleball when the weather's nice. I work full-time, but I recently got Wednesdays off through FMLA to give my neck and arm a break. I've also had golfers and tennis elbow in the past, and I do smoke about a pack a day. Sometimes I even have to switch hands because the pain flares up.
I have a couple follow-up questions. So in terms of pain, on a scale of 0 to 10, 0 being no pain at all and 10 being you have to go to the emergency room, how would you rate your pain on the worst, the best, and right now?
At its worst, probably a 7 out of 10. At its best, a 4 out of 10. And right now, 5 out of 10.
Okay, perfect. In terms of imaging, have you had any before?
Yes, I have. On my neck, it should be in the chart.
Okay, perfect. I see it right here. How often do you take breaks during work throughout the day?
Not very often, just during lunch, pretty much.
Okay. Have you had your workstation checked out for ergonomics?
I have not.
All right. Have you ever tried to stop smoking?
I thought of it, but didn't think I could do it.
All right, fair enough. So going through your systems review for blood pressure, I got 118 over 76, 76 beats per minute for heart rate with no abnormalities, and an 18 breaths per minute respiratory rate, 98% SpO2. Your integumentary system is intact. The musculoskeletal system has postural dysfunction noted. Right hand dominant. Postural assessment showed forward head position, left-sided trunk bending, slight right shoulder elevation. While the neuromuscular system showed radicular symptoms, pain, numbness, and tingling, and cognitive and communication was A&O 3 times. So going through the upper quarter screen for dermatomes, we had C6, C7, and C8 impairments on the right side, myotomes, numbness, and tingling in C6 and 7 on the right side, reflexes, decreased right-sided reflex in biceps, brachioradialis, and triceps. The median nerve tension test was positive with radiating and tingling down the right arm. The ulnar nerve tension test showed tingling down the right arm. The radial nerve tension test was negative, and the Sperling test was positive. Looking at the results for the upper quarter screen, C5 through C7, deep tendon reflexes were impaired on the right side with a positive Sperling. That indicates likely cervical radiculopathy, and radiculopathy is just compression of nerves causing numbness or tingling. So looking at your range of motion, using a goniometer for rotation and an inclinometer for all other cervical motions, extension was 50 degrees with pain, flexion was 45 degrees within normal limits, right rotation was 40 degrees with reproduced radicular symptoms into the thumb, left rotation was 70 degrees, which was within normal limits, right lateral flexion was 25 degrees with pain reproduced into the right shoulder blade and lateral neck, left lateral flexion was 40 degrees within normal limits and no pain reported. Overall, neck extension, lateral flexion, and right rotation were limited with painful end ranges in the right suboccipital and paraspinal areas. This indicates potential nerve involvement, joint dysfunction, and muscle tightness. So for the upper extremity MMTs, shoulder abduction was 4 plus out of 5 bilaterally. Elbow flexion was 5 out of 5 on the left and 3 plus out of 5 on the right. Elbow extension was 5 out of 5 on the left, 3 plus out of 5 on the right. Wrist extension was 5 out of 5 on the left, 4 out of 5 on the right. Wrist flexion was 5 out of 5 on the left, 4 out of 5 on the right. Thumb abduction was 5 out of 5 on the left, 3 plus out of 5 on the right. Grip strength or handheld dynamometry was the right side was 48 pounds and the left side was 60 pounds. The findings of this were limited strength in elbow flexion, extension, thumb abduction, and grip strength on the right side. For the deep neck flexor endurance test, 12-second hold time was achieved. Normative values for females is about 29 seconds. So there was a reduced deep neck flexor endurance, indicating impaired motor control and early substitution of superficial neck flexors. So that would be sternocleidomastoid and the scalenes. These findings suggest decreased cervical stability and may contribute to postural strain and recurrent neck pain during sustained desk activities. For the cervical distraction test, immediate relief of neck and arm symptoms yielded a positive result, and a positive result would indicate possible cervical radiculopathy. So I'm going to have you fill out this functional outcome measure.
Okay, I filled out the neck disability index.
You scored a 26 out of 50, and the MCID for this is 3.5. After finishing up all of these tests, we moved into manual therapy, therapeutic exercise, neuromuscular reeducation, and patient education. All right, nice to meet you, Sam. See you next time.
Thank you, bye!
Back to the office. Time to write my soap note.
All right, so first looking at some imaging, we have the C-spine x-ray. We can see that the patient's torque ratio was 0.6, which is less than the optimal 0.8, which is indicative of spinal stenosis. Next up for the C-spine MRI, we can see narrowing of vertebral bodies, as well as the vertebral foramen, which is indicative of compression of the spinal cord. Next up for the C-spine CT, we can see decreased space between vertebral bodies and spinous processes, as well as some osteophyte formations, as well as just decreased overall congruency, indicating, again, spinal cord compression.
For today's treatment, we did manual therapy, effleurage and petrissage, focusing on neck and upper back muscles, with also the therapeutic exercise. These include cat-cows with patient quadruped on mat, median nerve glides, each way cervical flexion, extension, rotation, and lateral flexion, active range of motion, self-assisted motion using both hands, doorway pectoral stretch, and each side upper trapezius and levator scapular stretch. For neuromuscular education, we did seated chin tucks with 3-second hold, a scapular squeeze with 5-second hold, and wall angels, and at the end we include patient education.
All right, so looking at some of our objective tests, some red flags we noticed, we do have some positive tests for neural dysfunction and cervical radiculopathy, along with limited ranges from pain and weaker right upper extremity MMTs, which are consistent with cervical radiculopathy or some type of compression at the C-spine nerve roots. All right, so the complexity of care would be a moderate complex case due to 1 to 2 personal factors. For history, having carpal tunnel, and they are a current smoker. For their body system examination, we did also notice we're addressing more than 3 elements, including C-spine, elbow, wrist, and hand, and their presentation is also evolving with pain increasing in that right arm. For functional diagnosis, we have diagnosed cervical radiculopathy on the right side, along with a secondary diagnosis of pain in the right arm. For prognosis, patient shows a good prognosis for significant symptom reduction and functional improvement given the patient's young age and history being active. However, there is a guarded component for a complete and long-lasting resolution if the ergonomic smoking factors are not addressed. Her history of multiple upper extremity issues may suggest an underlying systemic inflammation or a double crush syndrome, making adherence to the full plan essential for success.
To guide our plan of care, we were following the Journal of Orthopedic and Sports Physical Therapy Neck Pain Revision 2017, which was the neck pain clinical practice guidelines. Patient will be seen 2 times per week for 12 weeks and will be discharged to an independent HEP program to maintain gains in strength, mobility, and postural control. Patient will be instructed in a self-management plan for potential exacerbations and to follow up as needed.
Short-term goals. Patient will demonstrate independence with adherence to their HEP for postural stabilization by week 2, indicating patient efficacy and autonomous behavior. Patient will tolerate 60 minutes of computer work without an increase in cervical discomfort by the end of week 3 to allow for better work performance while typing. Patient will increase right rotations range of motion to 55 degrees by the end of week 4 to allow for better field of vision on the court. For long-term goals, we have patient will tolerate 120 minutes of computer work without an increase in cervical discomfort by the end of week 8 to allow for better work performance while typing. Patient will increase right arm elbow extension muscle manual testing to 5 out of 5 by the end of week 10 to allow her to return to playing pickleball twice per week. And lastly, patient will lower NDI score to 22.5 by the end of week 12, showing moderate disability to allow them to return to work 5 days per week. For future appointments, we'll include manual therapy, that includes soft tissue mobilization, joint mobilization, neurodynamic mobilization. The therapeutic exercise will include deep cervical neck flexors, trapezius, and upper back musculature, including activation and endurance training. And for neuromuscular reeducation, these will include periscapular motor control and mobility and flexibility. For modalities, we will have mechanical cervical traction, thermotherapy, and patient education.
For patient education, we're going to focus on ergonomics, postural re-education, activity modification, incorporating micro breaks, pain, neuroscience education, as well as smoking cessation. So these are a couple exercises that were included in today's treatment, our seated chin tucks, levator scapular stretch, as well as scapular squeezes. This is the printout that we would hand to our patient as they were leaving, and we would also email this so they had a digital copy. So we had an hour-long evaluation, 38 minutes of which was treatment time, which we built 4 units for. 1 unit for moderate complexity evaluation, 1 unit for therapeutic exercise, 1 unit for neuromuscular re-education, and 1 unit for patient education.